arriving soon. Namaste. Good morning, everyone. A warm welcome to all the guests and delegates gathered here today. It is both an honor and privilege to have you all with us in this program, Foundations to Fitness, Mastering Radio Orthopedic Skills for Clinical Practice. Radiology and orthopedics are deeply interconnected. What we see, how we interpret it, and how we act on it directly impacts patient outcomes. Today's program is designed to bridge that gap from the basics to refined clinical decision making, especially in day-to-day practice as well as emergency settings. Foundations to Fitness reminds us that mastering clinical skills is not just about advanced technology, but about knowing when to use what, why we use it, and how it changes management. I deem it my pleasure to invite our esteemed guests onto the dais, Dr. Ashok Puranik Sir, Executive Director, AIIMS Guwahati, Dr. L.S. Praveen Sir, COO and Senior Consultant Radiologist at Prima Diagnostics. He is also an advisor at Rashtrotthana Hospital. Dr. Mahesh Kulkarni Sir, Professor and HOD, Department of Orthopedics at Sri Chamundeshwari Medical College Hospital and Research Institute, Chenpatna. Dr. Anand Shankar Sir, Medical Director of Rashtrotthana Hospital. It is my pleasure to invite Sri Narayanji Sir onto the dais. He is the Managing Trustee of Rashtrotthana Hospital and a Treasurer of Rashtrotthana Parishad. Thank you, sir. Before we begin the academic proceedings, we shall formally inaugurate today's program by lighting the ceremonial lamp, symbolizing knowledge, wisdom, and dispelling of ignorance. I request our guests on the dais to light the lamp and inaugurate Foundations to Fitness. I would also call upon Ms. Meenu and Ms. Raksha to invoke the divine blessings through an invocation.
ಮನೆ ಮನೆಗಳಲ್ಲಿ
ಸದಾ ವಿಮುಕ್ತಿ ಸಾಧಕಂ ಕಲಾಧರಾವತಂಸಕಂ ವಿಲಾಸಿ ಲೋಕರಕ್ಷಕಂ ಅನಾಯಕೈಕನಾಯಕಂ ವಿನಾಶಿತೆ ಭದೈತ್ಯಕಂ ನದಾಶುಭಾಶುನಾಶಕಂ ನಮಾಮಿತಂ ವಿನಾಯಕಂ
ನತೇತರಾತಿಭೀಕರಂ ನವೋದಿತಾರ್ಕಭಾಸ್ವರಂ ನಮತ್ಸುರಾರಿನಿರ್ಜನಂ ನತಾದಿಕಾಪತುದ್ಧರಂ ಸುರೇಶ್ವರಂ ನಿಧೀಶ್ವರಂ ಗಜೇಶ್ವರಂ ಗಣೇಶ್ವರಂ ಮಹೇಶ್ವರಂ ತಮಶ್ರಯೇ ಪರಾತ್ಮರಂ ನಿರಂತರಂ
ಸಮಸ್ತಲೋಕಶಂಕರಂ ನಿರಸ್ತದೈತ್ಯಕುಂಜರಂ ದರೇತರೋಧರಂ ವರಂ ವರೇ ಭವಕ್ರಮಕ್ಷರಂ ಕೃಪಾಕರಂ ಕ್ಷಮಾಕರಂ ಮುದಾಕರಂ ಯಶಸ್ಕರಂ ಮನಸ್ಕರಾಂ ನಮಸ್ಕೃತಂ ನಮಸ್ಕರೋಮಿ ಭಾಸ್ವರಂ
ಅಕಿಂಚನಾರ್ತಿಮಾರ್ಜನಂ ಚಿರಂತನೋಕ್ತಿಭಾಜನಂ ಪುರಾರಿಪೂರ್ವನಂದನಂ ಸುರಾರಿಗರ್ವಚರ್ವಣಂ ಪ್ರಪಂಚನಾಶಭೀಷಣಂ ಧನಂಜಯಾನಿಭೂಷಣಂ ಕಪೋಲದಾನವಾರಣಂ ಭಜೆ ಪುರಾಣವಾರಣಂ
ನಿದಾಂದಕಾಂದಿದಂದಕಾಂದಮಂದಕಾಂದಕಾನ್ಮಜಂ ಅಚಿಂದ್ಯರೂಪಮಂದಹೀ ಮಂದರಾಯ ಕುಂದನಂ ಹೃದಂದರೇ ನಿರಂತರಂ ವಸಂದಮೇವ ಯೋಗಿನಾಂ ತಮೇಗದಂದಮೇವ ದಂ ವಿಚಿಂತಯಾಮಿ ಸಂತನಂ ಮಹಾಗಣೇಶ ಪಂಚರತ್ನಮಾದರೇಣ ಯೋನಹಂ ಪ್ರಜಲ್ಪದಿ ಪ್ರಭಾದಕೆ ಹೃದಿ ಸ್ಮರಂ ಗಣೇಶ್ವರಂ ಅರೋಗದಾಮದೋಷದಾಂ ಸುಸಾಹಿದಿಂ ಸುಪುತ್ರದಾಂ ಸಮಾಹಿದಾಯುರಷ್ಟ್ರಭೂತಿ ಮವ್ಯಪೈದಿ ಸೋಚಿರಾನ್ ಸಮಾಹಿದಾಯುರಷ್ಟ್ರಭೂತಿ ಮವ್ಯಪೈದಿ ಸೋಚಿರಾನ್.
Thank you. I now call upon Dr. Kavya to welcome the gathering.
Good morning, everyone. I deem it my pleasure to welcome everybody to this exciting day as we delve into understanding the nuances of diagnostic imaging, decoding the radiological films, bridging the gap between classroom and clinic, and moving from foundations to finesse. Today is about more than just looking at X-rays or MRIs. This is about understanding the stories that they tell. This day is a unique opportunity to learn how diagnostic precision directly translates to life-changing clinical outcomes. Firstly, let's welcome today's chief guest, an esteemed veteran, Colonel Dr. Ashok Puranik, sir, who is the Executive Director of AIIMS Guwahati. We welcome you, sir, to Foundations to Finesse, and would convey our delegates that our delegates are going to learn a lot from your knowledge and experience. I request Shri Narayanji to welcome him with a small memento. Thank you, sir. Now I'd like to welcome our two expert resource persons who are here to enlighten us with a plethora of knowledge and experience, guiding us from our educational foundations to diagnostic finesse. I welcome Dr. L.S. Praveen, sir, Senior Radiologist, COO of Prima Diagnostics, to today's program. I request Narayanji to present with a small Mahesh Kulkarni sir, Professor in HOD Department of Orthopedics, Sri Chamundeshwari Medical College and Research Center, Channapatna. I request Dr. Anand Shankar sir to welcome him with a memento. It's also my pleasure to welcome our Medical Director, Dr. Anand Shankar sir, to today's program, and our Managing Trustee, Sri Narayanji, to this program. Their leadership has been a major contributor towards the organic growth of our hospital in the past 3 years. And now, most importantly, I welcome all the delegates gathered here. You are today's focal point. The sessions are curated to focus on real-world experiences. We know that mastering these skills feel like learning a new language, and we are here to make you fluent in it. So we hope you leave here today not with just new knowledge and with a sharper clinical eye. Let's begin this journey from foundations to finish together. Welcome you all. Thank you.
Thank you, Dr. Kavya. It is our proud privilege to have a distinguished personality, Dr. Ashok Puranik sir, in our program today. He is the Executive Director of AIIMS Guwahati. Before joining this institute, sir was heading the Department of General Surgery as well as super specialty departments of trauma and emergency, gastrointestinal surgery, and plastic surgery at AIIMS Jodhpur. He has served as the head Department of Surgery and Trauma at the Command Hospital and AFMC Pune for a duration of 5 years. He was a trauma fellow at Alfred Hospital, Melbourne, Australia. He was commissioned in the Indian Army as a surgical specialist in 1985, and he initially worked in the northeastern states, which included a prolonged stint in the high altitudes carrying the soldiers and in the field area. During his illustrious service of more than 3 decades in the Indian Army, sir was involved in the field as well as peace tenures across the country and abroad, which included tenures in Nagaland, Kargil, and Sri Lanka. Sir has received numerous prestigious awards like GOC&C Commendation for Exemplary Services, Outstanding Clinical and Scientific Achievement Award in Trauma Surgery, High Altitude and General Service Medals, and he was also featured in Australian television network Channel 7. Notably, sir had also served as an army surgeon in the longest traveling ambulance train called Operation Dhanvantari, an effort which made into the Guinness World Records. We are truly honored to have you with us, sir. I request Dr. Ashok Puranik sir to kindly address the gathering.
Namaskara. How are you? I hope everybody fine. I'm really delighted, indeed, a very happy occasion that I'm part of the 3rd foundation day of this hospital. Mr. Narayanji, Praveenji, Maheshji, and Anand, dear friends, dear young doctors, I have a question for you. The Karnataka Bhavishya Idige. Karnataka ka bhavishya kahan hai? Where it lies? It lies right here with the young people. You. All bachelors, all young people, because after marriage you can't change the even TV channel, you know. So I wanted to start with a joke. I'm really delighted and very happy to be here among you. You see, the medical field is changing a lot, very rapidly changing. Every 5 years, whatever you learn gets outdated. A lot of new technology is coming. 3D printing, how many of you have heard? Augmented reality, virtual reality, mixed reality, regenerative medicine. You guys are going to survive for 130 years. Mind my words. How many years? 130, 140 years. That's going to be the normal age. You can marry as many as time you want. You will have a 4 times pension, 4 pensions. You are going to be rich. No need to conserve money. Elon Musk says, this generation doesn't need money. You know, You already have a money, you already have a house, you already have a car, you already have a bank balance given by your parents. What you need to do is that in life, you ought to be productive, you ought to be happy, you ought to be gelling with the people, you should be making friends, you should be in harmony with your neighbors. Thus the time has come. And with the advance in the field of medicine, we'll be able to change everything in the body. 95% of the body can be changed. You know, we are replacing the joints. We are replacing kidney transplantation. So soon we are going to have a heart transplantation already there. Lung transplantation is already there. It's just a matter of having a body transplantation and brain transplantation, which is very, very much possible in coming days. So people are into a lot of researches where in laboratory from your own tissue, organ can be made and it can be replaced. So I'm just trying to preach you the optimism and enthusiasm and life, what is going to be ahead. I believe we are going to have a soon symposium and discussion on radiology and the orthopedic combination, how they work together and how they gel together and how do they do their everyday work, you know. Among a very busy schedule, I came and I just got a telephone call that from a friend. Hey, where are you? I said, I'm very, very busy. He said, what busy? I said, I'm in a class. He said, what class? What subject? I said, I'm the subject. Wife was taking class. You didn't get the joke? All right, you guys. Okay, so I was telling you that the field of medicine is going to be very, very promising. And you guys are going to be the future of the country. The future lies in you. The energy lies in you. Another joke I can tell you about this. You know, when we are born, to keep us warm, what people do? They, you know, put in a warm sweater and warm wooling, some kind of a woolly cloth. So we think the गर्मी किसमें होती है? ऊन में होती है. Then फिर जब when we grow up, when we start going to school, we think the गर्मी comes from जून के महीने में. पहले ऊन में था, फिर अभी जून में था. Then when we grow up, when we become a very young guy, you know, bombastic and high in the hormones, people think गर्मी खून में होती है. नहीं जी, बाद में पता चला, we discovered later on that the real garmi comes from junoon, the passion. Keep your passion alive. Okay? Thank you for this applause. Okay. So I'm going to narrate a small story, and that has, I think I practice in my life, and I want you to practice in life. How many of you have heard the story of who packs your parachute? Raise your hands. If you have not read this story, please Google who packs your parachute. Okay, this is a story of a colonel, Charles Plum from America. He was a fighter pilot, a Kitty Hawk flights in Vietnam War in 1975. And his flight was short. He has to bail out, and through the parachuting, he landed. He was caught by the Vietnamese soldier, and he has to spend 3 months in 6x6 cell in the jail. 6x6, you can't sleep, you know, like that. And when he was released, when he went back to his life in America, one day he was having his dinner, and one guy came, he said, hey, are you Charles Plum? He said, yeah, how do you know? You were in Vietnam. Yes, I was in Vietnam. You used to be a pilot. Yes, sir. Yes, I'm a pilot. How come, what on the hell on this earth you know everything about me? He said, sir, I hope you had a safe landing. He said, yeah, that's why I've survived. He said, sir, I was the guy who packed your parachute. That night he could not sleep, you know. Look at this man, had he not packed his parachute nicely, you know, it's a very kind of a specialized act. Everything has to, like with the push-up button, it should work, you know. And it worked that particular day. He had asked him, Charles, did your parachute worked. Yeah, he said, I'm surviving because of that, because it worked. But Charles thought, I never looked at this particular guy, what rank he is, where he's sitting, what uniform he was wearing, how many times he saluted, where, in the deck, he must have said, good morning, sir. I never paid any attention to him. But that particular day, the life of Charles Plumb was on the parachute. Similarly, dear fellows, dear friends, our life depends on so many people, everyday life. Your driver, your gardener, your doctor, your nurses, your health carer, the guy who brings food for you, the guy who carries things for you. There are so many people who helps you in everyday life. The school bus driver who takes care of your children, the school teachers. So be grateful, be compassionate, do recognize, have a habit of saying a lot, thank you, and be compassionate. Do take care of your fellow beings. That's the message through this particular story. Another round of applause for this particular story. If you believe in the story of who packs your parachute. So in our life, there are so many personalities who contribute in our growing up, right from our school teachers to the doctors, to the neighbors, to the friends, to the relatives and everyone. So be respectful, be thankful, be grateful. That's the message. You want another story? Yes or no? I can go on. I have a time? All right, another story. This story is about the attitude. I have grown up with reading a lot of stories, and I never thought I'll become a storyteller and I'll be telling and sharing the story with the young people like you. You must have read this story, many of you. The temple are being constructed, and the one of the labor inspector goes and asks one of the labor guys, and what was going on here? What are you doing? He said, can't you see? I'm breaking stones. Don't disturb me. I'm doing my job, like that. This is the one guy, his attitude. The other guy, he says, I don't know, some temple is being made, and I'm earning my bread, and I'm just, I don't really care. I get my money, and, I'm happy and all that thing. Then he asked another third guy, and the third guy says, oh, I'm such a beautiful, lucky person that I got an opportunity to be part of this particular temple being made. I'm so grateful to the God. Such a my punya karma. मैं पुराने जन्मों का पाप भी पूरा हो गया और मैं कितना पुण्य का काम कर रहा हूँ. I'm associated with such a good work in life. Man, the situation is same. The work is same. But what matters is your attitude. So please have a attitude of a gratitude, Always be grateful, whatever you're doing, whatever way you are doing, what God has granted you, what God has given you. Okay? I think I'm sounding like a preacher. I should stop here. All right, let's come back to the medicine. All right. So today you are going to witness a lot of stalwarts over here who are going to talk about recent advances in the orthopedics, role of radiology, role of orthopedics, all those things. When it comes to the subject, I'll be chairing a session. That time I'll be coming again to talk to you and interact with you. Thank you very much for inviting me. I'm so grateful. Namaskara.
Thank you, sir, for such an engaging and informative talk. I now request our Medical Director, Dr. Anand Shankar, sir, to deliver the presidential address, setting the tone for this academic conference.
Respected Colonel Dr. Ashok Puranik sir, Dr. Praveen sir, Dr. Mahesh, Namaste Narayanji, distinguished faculty of orthopedics and radiology, esteemed consultants and residents, and all our future healers, our bright students out here. Very good morning to all of you. Namaste. It's my privilege to stand here, not just as a host, but as a fellow enthusiast in medicine. I'm excited to welcome you to the Foundations to Fitness, Mastering Radio Orthopedic Skills for Clinical Practice, a unique brainstorming session that epitomizes collaboration between two of the most dynamic disciplines, orthopedics and radiology. Over the next 2 hours or so, we will embark on a journey from basic principles to cutting-edge fitness. We will decode geriatric trauma, unravel the nuances of advanced imaging, and practice hands-on skills that bridge the gap between diagnosis and treatment. I extend my heartfelt gratitude to Colonel Dr. Ashok Puranik, who has inspired all of us with his wonderful inaugural address. Thank you very much again, sir. And for gracing us with his presence and wisdom. Sir, your illustrious career and commitment to academic excellence continues to inspire us all. I also would like to thank Dr. Praveen, who's come here, who was part of us and still is part of our advisory board, to come and spend his he's short of time, but he's made such an effort to come and be with us today. I thank you very much for that, sir. I thank you also, Dr. Kulkarni, for being here and inspiring and teaching the young students. I also thank the departments of orthopedics and radiology for their relentless effort in shaping this program, and to every participant and doctors out here who have chosen to invest this Saturday for an academic purpose to sharpen your skills. Our speakers, Dr. Praveen, Dr. Kulkarni, they're ready to share their expertise with us. Let's look forward to their insightful views on CT versus MRI, when, how, and why, and geriatric trauma, challenges and strategies, respectively. Let this session be a catalyst, igniting curiosity, fostering interdisciplinary dialogue, and translating into better patient outcomes. Wishing everyone a thought-provoking and enriching experience. Thank you very much.
Thank you, sir. I now request Dr. Sindhu to propose the vote of thanks.
Ano badraha kritavo yantu vishwataha. Let noble thoughts come to us from all directions. With this profound thought from our ancient wisdom, it gives me great pleasure to propose the vote of thanks at this moment before we proceed to the scientific sessions of the program. Foundations to Fineness, Mastering Radio Orthopedic Skills for Clinical Practice. On behalf of Jayadeva Memorial Rashtrotthana Hospital and Research Center, we thank our chief guest, Dr. Puranik Ji, Executive Director, AIMS Guwahati, for his insightful address. I would like to express our sincere gratitude to all the esteemed resource persons and panelists, Dr. L.S. Praveen Ji, COO and Senior Consultant Radiologist at Prima Diagnostic and Advisor at Rashtrotthana Hospital, Dr. Mahesh Kulkarni Ji, Professor and HOD of Department of Orthopedics at Sri Chamundeshwari Medical College Hospital and Research Institute, Dr. Surendra Ji, Consultant Orthopedic, Rashtrotthana Hospital, Dr. Nikhil Hegde Ji, Consultant Orthopedic, Rashtrotthana Hospital, Dr. Nagesh Ji, Senior Consultant Radiologist, Rashtrotthana Hospital, Dr. Prashant Ji, Consultant Radiologist, Rashtrotthana Hospital, who have kindly consented to share their expertise, clinical experience, and practical insights with us during the upcoming scientific deliberations. We are confident that their sessions will greatly enrich our understanding and clinical practice. I would also like to convey our deep appreciation to our managing trustee, Sri Narayanji, for his gracious presence and constant support for the program. I extend my heartfelt thanks to the president of this program, Dr. Anand Shankarji, who has graciously agreed to proceed over this event. His guidance and encouragement will continue to inspire us throughout the sessions ahead. We also thank Dr. Kavyaji for setting the tone for the program with warm and gracious welcome. Our gratitude also extends to all the delegates, colleagues, participants and friends whose active presence and keen interest will make the forthcoming sessions lively, interactive and academic rewarding. I would also like to acknowledge and thank the organizing committee, coordinators, volunteers, technical team and hospital staff who dedicated efforts and planning have made it possible for us to conduct this program smoothly and systematically. As we are about to begin the scientific sessions followed by quiz program, we look forward to a day filled with meaningful learning, healthy discussions and noble exchange of ideas. With these words, I extend my sincere thanks to one and all and invite you all to actively participate in the scientific session ahead. Thank you very much.
words and gracious presence. It is now time to advance to the much anticipated scientific session. Good morning, namaste. Myself, Dr. Gopika C, and I have the privilege of serving as the Master of Ceremonies for today's scientific session of our event, Foundation to Fitness, Mastering Radiological and Orthopedic Skills for Clinical Practice. Radiological interpretation and orthopedic decision making go hand in hand, particularly in trauma, emergency settings, and geriatric care. Today, we have an excellent academic lineup featuring sessions that are practical, clinically relevant, and enriched by real-world experience, making this program highly applicable to everyday practice. We begin with 3 scientific sessions, followed by a 4th session featuring a practical demonstration on retention and supports used in orthopedic cases. Our first talk will be on the topic CT with MRI, when, how, and why by Dr. L.S. Praveen, followed by an expert session on geriatric trauma by Dr. Mahesh Kulkarni, and then an insightful presentation on emergency room X-rays by Dr. Nagesh. Next, we move to a practical demonstration conducted by Dr. Sujayendra and Dr. Nikhil Hegde. To keep the momentum lively, we will then have a quiz competition under the guidance of Dr. Prashant. Finally, the day's academic program will conclude with a panel discussion where our distinguished speakers and delegates will engage in a meaningful and fruitful exchange of ideas. Delegates, please note, each delegate has been provided with a question slip in your kits. Kindly note down your queries in it, which will be collected by our volunteers and addressed during the panel session. Moving on to our first presentation is on the topic CT with MRI, when, how, and why, delivered by distinguished Dr. L.S. Praveen. Dr. L.S. Praveen, graduation in MBBS from Bangalore Medical College, DMRD from KMC Manipal, and DNB from NIMHANS Bengaluru. Dr. Praveen has created a rank as a renowned senior radiologist with 35 plus years of experience. He is the co-founder of Clumax Diagnostics and currently the Chief Operating Officer and Consultant Radiologist at Prima Diagnostics. Also, he serves as Senior Consultant Radiologist at the Bangalore Hospital, Jayanagar, Bengaluru. Please join me on welcoming Dr. Praveen to share his expertise on the topic CT with MRI, when, how, and why. Sir, please.
Good morning, all of you. CT versus MRI. I have changed that when to what, okay? What, how, and why. It will not be from what to how to why. We will keep jumping from either why to how to when and discuss. Radiology is a subject which will cater to almost all the departments. I think possibly the one which we will not be catering to is only anesthesiology. But there also indirectly a simple chest X-ray is required by the anesthetist. Radiology, the images, and we read the images. What are the things which we are dependent on? Simple 4 contrast. One is air, fat, soft tissue, and calcification. So any X-ray, simple chest X-ray if you take, you definitely see the air around the limb, the soft tissues you see, the fat planes between the muscle plane, you will see the fat plane and the bone. So now coming to CT versus MRI. Slides. Okay. Now, why do we require an imaging? We require imaging to visualize the internal organs non-invasively, to detect the disease at an early stage and to confirm your clinical diagnosis and to guide treatment and follow-up. Now, what is CT and what is MRI? CT, as you all know, definitely requires radiation, that is X-ray. X-ray in collimation. Collimation in the sense very thin line of X-ray will be going. And it is very fast. If you send a patient for a CT, for a say trauma, any pelvic CT or even head CT or even a spine CT or even whole body MR, whole body CT scan, the time taken is hardly 5 seconds to say almost around 30 seconds for a whole body CT. So in that way it is very fast. This is what you have to keep in mind. Next is, what is that it is used for? It is best for to assess bones, assess the lungs, assess the bleed, especially the and definitely there is radiation exposure. What is MRI? MRI uses magnetic field. I will not go too much into physics of MRI. There, putting a person in the MRI, we will, and then inducing a radio frequency, we obtain the images which will be computed and you will get the images. And it takes really, it is relatively slow. And any movement, whatever minute movement also, you are going to lose the quality of image. And it is very, very best for soft tissues and bone marrows. Absolutely no radiation. Now computed tomography, it is nothing but an advanced X-ray based imaging, producing cross-sectional images, and whatever images which you get, the thin images we use and reconstruct into sagittal, coronal or any oblique reconstructions. And the images are based on tissue density differences. Now this is the pointer. Okay. Now for those of you how to this is the, no, this is, okay. This whole thing is the gantry which will be housing the tube and the detectors. And this will be the table on which the patient is laid down. The patient moves into the gantry and the X-rays are emitted and X-rays literally cuts the patients, and you get images which are computer reconstructed and axial, coronal and sagittal images. So the X-ray tube rotates around the patient, the detector measures the X-ray depending on the attenuation, and different tissues absorb X-rays differently, so you get so computer reconstruct the axial images. Now this is spiral CT, and this is the physics behind the single slice CT and the spiral CT. In single slice CT, what is there? It is only single row of detectors, X-ray omits, and the patient moves. Again one more thing, again the detector detects, like that. Here the patient will be moving in real time and the X-rays will be coming in real time, and you have got multiple detectors and you get multiple slices, thin slices, where in reconstruction of the images you will be getting beautiful images. Now what are the wordings which we will be using? Is one is hyperattenuation, that is hyperdense, like what you are seeing is bone. This is hyperdense. Hypoattenuation, this is the fat tissue what you are seeing, and the fluid what you are seeing is all hypo. Isoattenuation, whatever lesions which are iso, that is equivalent to brain parenchyma or even liver parenchyma, are all iso. And attenuations are measured in Hounsfield units. Like minus, if you measure the Hounsfield unit here at where there is air, you will get out minus 1000, and 0, that is the CSF will be 0, and when you go for cortical bone it will be 1000. Now what are the things which are bright on CT? One is bone, Another is the contrast, what you are giving contrast. Another is hemorrhage, which I will be showing you. Hemorrhage will be which will be bright, and hypercellular mass and metallic foreign bodies. And things which are dark on CT are air, fluid, fat and lungs. Okay. The fractures, because I told you about what is best seen on CT is between CT and MR, fractures are better evaluated on the CT. And this is just for I just wanted to show you the lungs. Whatever that is black is all air which appears black. What are the advantages of CT? One is fast scan time, and especially for trauma patients, wherein the patients cannot be positioned, which we have to do in MR. We don't have to do, I can do it in decubitus position, I can do it in prone position, any position. I don't have to fix any coils or anything as we do in MRI. And then it is an excellent modality for evaluation of hyperacute bleed. Calcifications, pediatric patients, again, pediatric patients, because the time taken is very less. Pediatric cases, I can do of the whole body CT within less than a minute. And it is definitely cost effective when compared to MRI. MRI, for a simple MRI of brain, if you can just reduce the light, it is really irritating. So for a simple brain CT, they will be charged about 3,000 rupees on a CT, whereas for MRI, you will be spending almost around 8 to 8,500 depending on the place where you go and get it done. Number one, there are no sequences in CT. I can just do off about 8-second scan and get you brain, I can get you the bone window or even soft tissue window, anything I can get. But on the contrary, thank you. But on the contrary, for an MR, simple thing is, the most, I would rather say is, even to house an MR in a hospital, you have to literally look where exactly you need to place it. There should not be movement of any vehicles for about up to 10 meters or so, or there should not be any magnetic things either above, below or to the side for about 10 meters. So there are a lot of restrictions. Number two is to get an MRI of the brain, you cannot just do it in 8 seconds. It will take almost, to get a simple MR brain, it will take about 15 to 20 minutes. So in that way, the time taken in MR definitely is more. What are the disadvantages of CT? One is radiation, as you know, but radiation is a must, or else I cannot get the image. It cannot be done in pregnancy, inverted commas, pregnancies less than 3 months. More than 3 months, again you will have to evaluate the patient whether you can go ahead with, whether you have to go ahead with a CT. Yes, you have to go ahead, then go ahead with the CT, or else if you have a MR, go ahead with an MR. And when you require iodinated contrast, there are two problems. One is the patient has to be fasting at least for about 3 to 4 hours, and the chances of reactions definitely are there. And multiplanar imaging is not possible. That is, straight away I cannot get a coronal cuts, or straight away I cannot get sagittal cuts, but wherein in MR I have the advantage. Now coming to MRI, how do we get? Using strong magnetic fields and radio frequency, and there is no ionizing radiation. This is the MRI equipment wherein the patient is made to lie down here, and he or she has to go into the gantry there, and this whole thing will be full of magnets. What do? Patient is placed inside the magnet, and we put a radio signal. Because our body is full of water and we have hydrogen ions there, we use the hydrogen and get the images. And once the radio wave is sent, the hydrogen protons, they will align in one particular thing. At that particular moment, we get signals which are received and used for reconstruction of the image. The signals again depends on the property of the tissue. What are the terminologies we use? Hypointense, which is black; isointense, whether it is similar to brain or similar to liver or similar to that particular parent organ. And hyperintense is whatever that appears white. And hypointense on T2 and T1, T2 hypointense on T1 and T2 sequences are those which are moving, that is flowing blood. Flowing blood does not give any image, any signal, so it appears black. And cortical bones and air, these three appear hypo, that is they appear black. Now, fluid appears dark on T1, you can see the CSF fluid here, and you can see the subarachnoid space which are appearing black. This is T1. Fat appears bright. This is a subcutaneous fat which is appearing white. Then fluid, how it appears on T2? The CSF, what you are seeing as black, appears as white. And you can see the subarachnoid fluid appearing white. And fat appears less bright compared to T1. Now, here also we use contrast media like gadolinium. Gadolinium, a paramagnetic substance which will enhance the lesion. Now, there are few contraindications, like these are all, as of now, they are all relative contraindications. I have mentioned it as pacemakers. Yes, now pacemakers, now we get MR compatible pacemakers, you get MR compatible aneurysm clips, you get cochlear implants. I am not very sure whether we are getting MR compatible. And claustrophobia, it is totally relative because patients are afraid to go into the tunnel. This tunnel. What happens once you go there, the gantry is straight in front of the face, right in front of the face. So even if you want to get up, you will not be able to get up because you are covered with the coil. Now, what are the advantages of MRI? Absolutely no radiation, excellent soft tissue resolution, multiplanar imaging is possible, and there is no need for fasting even for contrast study, absolutely no need. And the contrast which is required also is around hardly about 7 to 10 ml. So these are the images which you are going to get directly, but not in CT. CT you have to reconstruct the image. Here it is multiplanar, you can get the axial image, you can get coronal, you can get SH directly. That is the reason why it takes more time to get MRI images. Without contrast also we can get an angio, it is called as what is called as TOF, time of flight sequence. This is for venogram, and this is with contrast which we are showing all the circle of Willis and other branches. Are you able to see this, or is it covered? See, this is in T1 sequence, we are seeing some hypodense, but we are not very sure about it. This also, we are not very, this is diffusion weighted and ADC, and this is an angio wherein you can see a MCA, left MCA is well seen, but right MCA is not well seen. So this again is without contrast. Now choose CT when? when the patient is very, very irritable, who cannot lie down. In those cases, even if you get a CT, at least you will get some idea as to whether there is a bleed or there is a fracture or something like that. And when you really want to see bones, especially for orthopedicians, yes. And lungs, when MRI is contraindicated, that is when the patient has pacemaker, metallic implants and claustrophobia. And choose MRI when you don't want radiation, and repeated imaging is required, especially for chronic patients. And pregnancy, again this is a debatable subject. After 3 months, nowadays there are studies which says even before 3 months also you can get it done. Now CT is preferred when there is an emergency, when there is a need for speed, and when you require bone detail, when you want to assess lungs, and when there is acute bleed. And MRI is preferred whenever there is brain and spine lesion. Whenever you have a lesion, when you are suspecting a CNS lesion, please go ahead with MR if it is not in emergency. And better soft tissues, marrow assessment when you want to assess the ligaments and subtle inflammations. Now I just want the audience here to let me know. 68-year-old man present to the ER with sudden onset of right-sided weakness, slurred speech, altered sensorium for 1 hour, BP 190, 100. What is the first modality of choice? You have MR brain with contrast, MR diffusion, CT brain, CT angiography. Any takers? What? CT brain non-contrast. If the patient is stable, you can even go ahead with MRI also. Now, 24-year-old man present after road traffic accident, loss of consciousness and vomiting. What is that you are going to do? Best imaging modality which is required? MR, CT, X-ray skull or ultrasound head? CT. 32-year-old man presents with recurrent headaches, visual disturbance for 6 months. This is very important, 6 months, no acute symptoms. Then I would rather go ahead with an MRI. Then here again, 26-year-old pregnant woman. What is that needs to be avoided if possible again? That is avoid CT abdomen. 55-year-old smoker, chronic cough, weight loss, hemoptysis. What is that? You are not going to do anything with MR. So go ahead with CT chest. So again, to summarize, when to choose CT, trauma cases, pediatric patients, reduced when you require speed, when brain evaluation in acute settings, suspecting intracranial bleed, penetrating injuries and fractures, you go ahead with CT. When you choose MRI, when you are suspecting vascular abnormality, subtle inflammation, tumors, infections, chronic or subacute hemorrhages, headache evaluation, fetal assessment, any CNS pathology, brain or spine. So, this is a case wherein you have got a hyperdense MCA sign and very subtle changes in the brain, like whatever your Sylvian fissure, what you are seeing, you are not seeing. The cortex and medulla, you are not seeing well. So, hyperdense MCA sign with effacement of cortical sulci and Sylvian fissure is MCA infarct, which is very well seen here. You can see MCA being absolutely not seen. So, oligodendroglioma cases, this is done with CT. See the lesion, how it appears here and how it appears so well it is seen. So, clinical pulse, CT is required when speed is required, bone, lung or bleed to be assessed. MRI when you want detailed soft tissue and it is for CNS. Always match clinical urgency with imaging modalities. Don't forget basic X-ray and ultrasound. For every patient, you don't require a CT and MR. Even getting just basic X-ray or even ultrasound, it will help you. When in doubt, please discuss with radiologists. What is the take-home message? Always take proper history and do the clinical examination. This is very, very important. Without this, I don't think even radiologists will be of any help to you. Decide the modality based on clinical question. Communicate clearly with the radiologist what exactly you want, what is the information. We will tell you whether CT or MR. And provide relevant clinical history, suspected diagnostics, and what is the area of interest which you are looking for, and whether the contrast is required or not. Radiology, as I said, is a clinical specialty. Imaging must answer your question. With this, I come to the end of this session. I hope I have made it clear for you. In case there are any doubts, please do feel free to discuss with me. Thank you.
Thank you, sir, for your insightful words and for graciously honoring us with your presence. With that, let us now proceed to our next scientific session. Next, we have an expert session by Dr. Mahesh Kulkarni, who will be speaking on geriatric trauma. This promises to be a highly insightful discussion. Dr. Mahesh Kulkarni, consultant orthopedician, Rashtrotthana Hospital, Bengaluru, Professor and HOD, Department of Orthopedics at Sri Chamundeshwari Medical College, Channapatna, Karnataka. Dr. Mahesh Kulkarni comes with extensive experience in clinical orthopedics, trauma care, arthroplasty, arthroscopy, spine and sports medicine. An MBBS graduate from Bangalore Medical College and MS Orthopedics from Government Kilpak Medical College, Chennai. He also holds a DNB in orthopedics and has completed multiple advanced national and international fellowships, including joint replacement, arthroscopy, spine, trauma, and sports medicine in India and Germany. With over a decade of hands-on experience across tertiary care institutions, Dr. Mahesh Kulkarni has actively contributed to undergraduate and postgraduate medical teaching, a prolific researcher with numerous publications in reputed national and international journals. He regularly participates as faculty, examiner, and resource person in academic programs, CMEs, and surgical skill workshops, reflecting his strong commitment to evidence-based orthopedic pediatric practice and medical education. With great pleasure, we invite you to grace the stage and lead us onward. We welcome you, sir.
Hello. Okay. Am I audible? So today I will be talking about a very important topic, that is fractures in the elderly people and the trauma in the elderly people. So as we all know, most of us have come across the multiple incidences in our family or among the friends in whom there are elderly people who are really active nowadays, and they are participating in most of the physical activities, and they do really take care of their health. But because of aging and all other associated comorbidities, and they are facing some of the issues about which I will be trying to highlight you guys and to make you aware of the facts and the possible assessment, evaluation, and then possible treatment, and to get to the uh, best of their ability to get back to their regular lifestyle. It's okay. Sir, it is functioning there. It is functioning. Yeah, that they have. So while they set up the things, so I will just like to highlight few base points here. Here is a 70-year-old male who had come to us with the history of fall while taking a bath in the house, and he is a known case of diabetes mellitus, which he is not under control, and he is substance abuse, that is alcoholic. And then on the day of the presentation to us, he is able to communicate with us, and he is able to tell his name, location, and the time, and he is oriented, very well oriented. He is able to explain all these things to us and also to helping the nursing staff. But because of the associated comorbidities, we were not, and also the attenders were a little hesitant to take him for a surgery, which we suggested, which should be done at the earliest. So there was a delay in taking him up for the surgery, and this is his condition at the 4th day of the admission. As you can see, he is a little bit disoriented, he is drowsy, not really responding well to our commands, and he is not able to follow our wordings also. So this is what we see typically in elderly people who have suffered some fractures and other things. So whom do we call it as a geriatric patients? The people who are cutoff is about 65 years, and there are multiple definitions, but usually we will consider anybody who is older than 65 as a geriatric patient. And here I would like to stress you upon, not upon the number, but it is a physiological state of that particular person. And in this session, we will try to identify the pathophysiological changes which happens in elderly people, and we try to understand the needs following the fractures, and we try to develop some skills to manage a geriatric patients efficiently. Coming to the demography, so as we all know, there is a global rise in the elderly population, and that is because of availability of the better healthcare in most of the part of the world except sub-Saharan countries. And there is a dramatic increase in the life expectancy, but there is a questionable health span, which you call it as a disease-free ages, okay, but that has not progressed dramatically, and hence we are seeing many health related issues in this age group. So coming to the demography from our Indian standpoint of view, so this is the population pyramid which we see as of now in the second and the third decade, where the elderly population is relatively less, which constitute about 8 to 10% of our population as of now. So in coming next 20 or 30 years, by the time you guys become a consultant, and then by the time you start your practice, and when you are in the field, you tend to see a majority of the patients who are in this age group. So all the more important that you focus upon this topic. So when I become old, I presume you guys are the one who are going to treat me, okay? So why are we focusing so much upon these geriatric fractures or a trauma? Because we have a substantial health concerns. It increases the disability, it reduces the quality of a life, it is a financial burden to the family, to the person, and also to the society as well, because the resources has to be kept aside for this. And there is an increase in mortality risk. So any fractures in elderly population, there is a mortality rate of 10% in the first month. And hip fractures, at the end of the 1 year, you will not see 3 out of 10 people around us. Okay, so that is very high mortality rate. And of late, this 65 number is disputed because of the physical activity and the lifestyle and the changes in which our people are like anticipating health concerning. They are taking care of their health. They are becoming really active. And in these people, in the elderly people, we tend to see the reduction in the high velocity trauma. Usually what we see is the fall from standing height, slipping from the stairs, slipping in the bathroom, fall from a little bit, couple of stairs, and these are the common mode of injuries. And but even with that trivial fall, there will be an increase in morbidity and mortality. So the question is how to get them back to pre-injury level of activities. So what are the main causes for the what are the main causes for the geriatric fractures? One is a fall, second is a road traffic accident, and the another important aspect which is not very highlighted is the maltreatment. If you go and see any news channels, daily there will be 1 or 2 reports of abuse of elderly people. Okay, so that is also adding to the etiological causes. So why these people fall? Why there is a increased chances of road traffic accidents? Because of the reduced flexibility, lack of coordination, gait disturbances, reduction in the visual and auditory acuity, vertigo, dizziness, and they might have altered judgment, and then medications which they might be taking in couple of numbers, and effects and the side effects of those medications can cause these falls and traffic accidents. So another etiological cause, as I mentioned, is elderly maltreatment, which could be because of financial or material exploitation, willful neglect, physical assault, and assault also could be psychological, with which they suffer and they end up falling and suffering the injuries. So coming to the geriatric fractures, geriatric trauma, these are usually, as we discussed, are low velocity trauma. They can have injuries to the head, chest, abdomen, and musculoskeletal injuries, and pre-existing disease history or medications, whatever the patient is taking, and we need to assess them on par with the young adults, plus we need to give extra importance also for their pre-existing diseases and medications. So to start, basically there is a ABCD, which is a part of our ATLS protocol, that is Advanced Trauma Life Support. First is the airway. So airway is of a prime importance. We need to establish and ensure to maintain that airway, and so as to maintain the oxygenation, and we should have a low threshold for early intubation. We need to avoid a manipulation of a cervical spine, and if necessary, we need to do the cricothyroidotomy to ensure the airway. And because of a stiff chest wall, they are bound for a multiple rib fractures, and because of underlying conditions, they will have a pneumothorax, hemothorax, and lung contusions. So all of these adds up and leads to the respiratory failure. And principles are, we need to control the pain, apply a rib binder for fractures, and we can ask for a CCT chest to contrast enhanced CT to ensure the diagnosis, and then if needed, intercostal draining tube should be installed. So these patients coming to the circulatory system, they have an increased blood pressure because of age. There will be increase in the peripheral vascular resistance, which limits the cardiac output, and that leads to the hypoperfusion and sequential multi-organ dysfunction. And we are supposed to maintain the hemoglobin at least minimum of 10 grams, so as to ensure the proper perfusion of the tissues. And while resuscitating, we need to be focusing upon the volume what we transfuse to these patients. If we cause a volume overload, that can lead to the pulmonary edema. And if we don't, then they might have a hypovolemia and a hypertension. With underlying coronary artery disease, they can go for a shock. It's a fine balance which we need to maintain in these people, so they need a proper care. And because of the fall or injury, they are bound to sustain intraabdominal injuries, and that can be assessed by FAST, which is a focused assessment sonography in trauma, or we can take a help of CT abdomen scan, as sir mentioned earlier. And these injuries to be managed by an expert trauma surgeon. And these people, these geriatric people, they have a high propensity for a head injury because of the shrinking of the brain and then increase in the subdural space. There is a tendency for a brain to move too much, and they can have a coup and counter coup injuries, and that leads to the stretching of the parasagittal veins, which are very fragile. Veins are really fragile and they tend to rupture, and that can increase the severity of the head injury in elderly people compared to the younger persons. So, brain injury, added hypertension with metabolic acidosis, which happens because of a respiratory failure, has a high mortality in elderly people. Coming to the musculoskeletal, these people tend to have multiple fractures. Main things are the spine, proximal humerus, proximal femur, distal radius, pelviacetabular, and also they can have fractures with the dislocations. And main reasons are the decreased quality and quantity of the muscle, which we call it as a sarcopenia, which is usually associated with osteoporosis. Because of their age, they will have a stiff joints, which is osteoarthritis, and we need to keep our eyes open for the secondaries or the malignancies in this age group, because the incidence of malignancy in these people is much higher. So, if you suspect there is a malignancy which can have a secondaries in the spine or the limbs, then the best way is to go evaluate in depth and address the condition accordingly. And whenever these patients come to us, and whenever you are suspecting the spine injury, be really careful. Because of the stiffness in the spine, they tend to have a severity of the fractures and the dislocations at the much higher level, and they can have these spinal cord injuries. For this, we need to evaluate them in detail, and we follow the Asia grading in classifying these things and then following it up. When you suspect any spine injury, so first thing is to immobilize. Either you can use a Philadelphia collar and a spinal jockets. When out of a hospital situation, my colleagues will be demonstrating you what all to be done in such cases in the outskirts or peripheries where the resources are not available. So, there is a concept called as a log rolling, and we have to use the spine board to transport these people. And the CT and the MRI are must for these cases, so as to evaluate the level of injury and the severity, and to some extent that gives us a prognostic idea as well. So, whenever there is a musculoskeletal trauma in the extremities, first thing we need to stabilize the patient, and then we come to the extremities. Okay? This is as per the ATLS protocol, and we have to splint the fracture limb. Open wounds, then we need to give a thorough wash and a dressing. Open wounds with active bleeding, just apply dressing and apply the compression, and exploration need to be done in the operating room. Don't waste in the periphery or in the vicinity where there are facilities are not available. So, one thing you need to keep your eyes open is the compartment syndrome, and you need to assess the vascularity. So, once the patient is stabilized initially, then we need to ask for relevant radiological investigations, which could be trauma series X-rays, ultrasound abdomen and pelvis, Doppler or a CT angiogram, and bar CT or MRI as relevant. And coming to the elderly people, their skin and the connective tissue is really fragile, and hence the thermal regulatory mechanism is quite low, and they are susceptible for hypothermic injuries. Okay? And hypothermia causes worsening of outcome in these patients. And after the admission, this has to be under specialist care, either a geriatric medicine or a general physician or a emergency medicine who are taking care of these people, and their respiratory status has to be monitored regularly. Because of underlying coronary artery stenosis, myocardial diseases and weakness in the cardiac muscles, these people tend to have a higher complications rate for angina, arrhythmias or cardiac events. And because of the age, the functions of the kidney are reduced in these people, and they are prone for a renal failure. That also has to be monitored regularly. And coming to the fractures, what are the challenges we face in these people? Because of osteoporosis, the quality of the bone will be really low, and then because of the soft tissue and sarcopenia, the attachments to the bone are less, and hence the reparative process is really slow, and they also have a local and systemic issues, and that lead to the increase in the complications in these people. That is a malunion, non-union, delayed union, failure of our fixation, complications with the wound, and they can go for a higher rate of infection, which will lead to the osteomyelitis. So what are the strategies we use in these people to fix the fractures? One, we replace that particular part of the bone if it is replaceable. We call it as a arthroplasty. Some of the implants we use, we call it as a locking plates, which are angle stable implants. We use a load sharing devices, which are nails. I will show some of the examples. And we can augment these fixation methods. We can use a minimally invasive techniques, and some of the elective and selected cases, we can treat them non-operatively as well. Undisplaced fracture of the pelvis, if the patient can tolerate rest for a couple of days, then we can continue with the non-operative management. So our goal is to achieve early recovery so as to get the stronger reconstruct in the bone, relief of a pain, so that to make the patient weight bear immediately, and try to mobilize early and to provide a better nursing care. So post-operative care is a must, and it is very crucial in these people. In a chronically bedridden patients, we need to focus upon the frequent change of a position, upright or witness, or Riles tube feeding to be done, so as not to leave the patients for the complication of aspiration pneumonia. And we have to mobilize the patients if at all possible out of the bed, and if it is not possible, at least you try to mobilize all the joints, give the chest physiotherapy properly to the patient so as to avoid the pneumonia and other complications. DVT prophylaxis is a must if there are no contraindications. Otherwise, we end up seeing a patient suffering from a pulmonary thromboembolism. So the same patient which we discussed earlier in the beginning of our discussion, so this guy had a left side distal femur fracture which was comminuted, and it was treated with the minimally invasive MIPO technique where the angle stable implants were used, and he has been made to walk after the initial fixation. And then once we mobilized him out of the bed, in a couple of days he was ready to get discharged, and the family was really happy. So there is another patient who is a 65-year-old female with a history of a slip and a fall, who is a debilitated patient. As you can see here, she had a comminution, and there is a lot of fragments here. So it's a really complicated case to fix, and we have to use this angle stable implants, that is LCPs, and then we could get the good reduction in this lady. The other injury, this one was treated conservatively in this case. Because we could mobilize her in the bed, we were able to make her sit in the bed, and also to mobilize the upper limb and also the lower limb. So we accepted that, and then and she is better now. And coming to the another case, this is a case of one 85-year-old lady who had a history of fall in home. She is a granny of our colleague, and she suffered a D12 wedging fracture. As you can see, there is bones are really not of a good quality, and because of comorbidities, we planned for conservative management. She was doing really good for initial 3 to 4 weeks. We had just mobilized her in the bed, relatively low mobilization. But on the 4th week, she started suffering weakness in the lower limb, tingling sensation, and loss of a grip in the foot and all that. So we had to admit her, evaluate her, and the MRI showed there is a retropulsion of the fragment with complete stenosis of the spinal canal, and that was the reason for her worsening of the neurological status. And if you see the CT, you can see here. So this is almost a flat vertebra here, and yeah, these are the fragments which were pushing on the spinal cord, and that was causing the symptoms. So we had to take her up for a surgery. We had to extend fixation by another level, and we had to decompress posteriorly, and this fixation was done. Immediately after the surgery, the next day she was able to sit, walk, and she was really happy, and she is recovering really well. And this is another case of 70-year-old female who had a fall in the home, and then they went for a native treatment, considering that if we go to the doctors, they might suggest surgery, and they were afraid. And obviously she had a hypothyroid, diabetes mellitus, and grossly obese. Okay? And after 2 years, she came to us with a stiffness of the hand and instability basically. She is not able to use her hand because there is a non-union, established non-union in the radial head as well as the ulna, proximal ulna, as you can see here. So these are the complicated cases, and we had to replace that part of the radial head, use the same part here as a bone graft. So this is the part of the bone which has been replaced, and she is doing well now. And the next case, the 60-year-old female who fell down in the home, and she was not having a consciousness. So she was admitted in the ICU, she was intubated, GCS was quite low. So they were not sure what is happening. Then they took a CT, then they realized there is a hemorrhagic bleed in the brain, and that was the reason for low GCS, and she was not gaining a consciousness. She was on a ventilator. And on third or fourth day, they realized she is having difficulty in moving the hip. Obviously, she was bedridden, she was not moving the hip, but whenever they are trying to move her in the bed, she was complaining, she was wincing. So they realized there is some problem, so they took a X-ray. As you can see here, she is morbidly obese. So this is the femur bone, and this is the margin of the soft tissue. Okay, very obese indeed. So they were not able to identify immediately, but once we took the X-ray, then we realized there is a lot of comminution and a fracture. Here, the importance of the family comes into the picture. Patient is ventilated. Patient is not conscious, alert or oriented, not responding, and there is a little chance for a survival. But the family took a lead, and they asked us to fix it because whenever they are trying to move the patient in the bed, she was wincing a lot because this was causing a pain, obviously. This is a major bone in our body, and if there is a fracture and we try to move, it hurts a lot. So we took a risk, and we fixed it, and the nursing care went on. She was bedridden for about 3 months, and then about 5 to 6 months later, she was able to sit and stand. The attendants were very happy. They took a call. It was a hard call, really. Another patient, 60-year-old female, otherwise normal, about 1 week ago. And then she tried to lift something while coming from the shop. And then she felt a pain in the back, and we took a X-ray, and the X-ray looked really not great. Okay, so if you see the quality of the bone and all, that is really bad, and as you can see here, there is aortic calcification that shows about age, and yes, and we probed further, and then we took a CT, and a CT shows multiple lesions from D8 to D11, multiple fractures, with some lytic lesions extending up to the sacroiliac and also the pelvic region. So she was evaluated, and then she found to be positive for a multiple myeloma. She went in for a chemo for 2 sessions. Then she came back to us with intractable pain in the back. So we had to go in and fix from a D6 to L1 with multiple screws with a staggered fixation. So she is doing better now. Obviously, she is on chemotherapy for her multiple myeloma. So far so good. So we are fixing everything. So then why to worry? So is that job done? No. So the nature has got some, yeah, give backs to us. So this lady, she is a 75-year-old now, inflammatory bowel disease, and she is having a colostomy pouch since last 25 years. And right side she had a shaft of femur fracture 1 year ago, and she was on and off treatment for anti-osteoporotic measures. And right side fixed well, and one fine day she was trying to move out of the bed, just trying to move out of the bed, and she felt a snap, and she had suffered this left shaft of femur fracture, and this is stress fracture, and this had to be fixed, and now she has to put back on her other medications. Another lady, 75-year-old, 78-year-old, she came back to us with the trivial fall while trying to sit. She slipped and she sat on the sofa. Okay, so she is having a back pain, and she came to us. We took an X-ray. Then she gives a history of a similar incident previously, for which there was a vertebroplasty was done, and she was asymptomatic for now. And then recently, when she tried to sit, she had fractures again, adjacent vertebral fractures. So 2 months and couple of months. And another patient was alcoholic and had to undergo total hip replacement, but not following instructions, had a fracture there. So what are the issues? We need to focus upon their medications. We need to focus upon the maltreatment, and there is a recept concept of do not resuscitate, which is in the legal domain, which is not clear yet. So to conclude, if you take these 3 points, so that should be enough. One is age increases the mortality from the injury. Team effort improves the survival of these elderly people, and our goal is to restore the elderly patients to their pre-injury medical status and independent state. So thank you. Any questions you can clarify later. Thank you.
Thank you, sir. Delegates, next we'll have a small short tea break. Tea has been arranged on the entrance of auditorium, requesting all the delegates to kindly collect it and be seated in your respective places as soon as possible. We'll be starting the next session in another 2 minutes. Delegates, please note, kindly come back to your respective places in another 2 minutes due to security concerns.
Health does not merely mean freedom from illness. True health lies in nurturing both the mind and the body, while continuously striving for holistic well-being.
Delegates, please note, kindly come back to your respective places.
Guided by
Due to
this
security
profound
concerns,
philosophy, our journey
next
in
session will be
healthcare
starting
began
in
in
another 2
December
minutes.
2022. Over the past 36 months, the path we have traversed has not only brought us deep satisfaction, but has also strengthened our sense of responsibility to serve society with even greater dedication. Our hospital stands apart through its integrated approach to healthcare, bringing together modern medicine with Ayurveda, homeopathy, yoga, and naturopathy. Within just 3 years of inception, we have achieved full NABH 6th edition accreditation, a rare and significant milestone that reflects our commitment to quality and patient safety. The mission of Jayadeva Memorial Rashtrotthana Hospital is to deliver high-quality professional healthcare at affordable costs, guided by strong ethical values. In alignment with this mission, over the last 3 years, we have provided compassionate care to more than 2 lakh patients and successfully performed over 4,500 surgeries. Our team of renowned specialist doctors focuses not only on treating physical ailments but also on addressing the emotional and mental well-being of every patient.
Dear delegates, kindly come back to your respective positions. We are starting
Our
with the next
approach
session
emphasizes treating the root cause of illness, complemented by free guidance on healthy living and preventive care. To ensure accessibility and convenience, especially for working individuals, we have introduced evening clinics and Sunday clinics. With the vision of integrating diverse healthcare disciplines and promoting patient-centric research, we have also established the Rashtrotthana Research Center. We have formed an ethics committee comprising experienced experts from various fields dedicated to upholding the integrity and ethical standards of our research. We are currently in the process of securing National Board of Examinations in Medical Sciences NBEMS accreditation as a Diplomat of National Board DNB Postgraduate Center, having successfully fulfilled the required norms, and will soon offer DNB programs in general medicine, anesthesia, and family medicine. Every member of our team works with a single heartfelt goal that each patient admitted to our hospital recovers swiftly and returns home in good health. Our commitment to service extends far beyond hospital walls. We operate a daycare center that provides free blood transfusion services to children affected by thalassemia.
We request all the
currently
delegates to
supporting
come back
more
to
than
the
400
auditorium.
children. Driven by humanitarian
Requesting
concern,
all
we
delegates
launched the
to be
Clinic
back on the
Wheels,
auditorium.
a fully equipped mobile medical unit that reaches nearby slums and villages to offer free healthcare services. To date, more than 35,000 individuals have benefited from this initiative. Through free health camps conducted across the city, including orphanages, old age homes, and schools, over 50,000 people have received essential medical care. Additionally, more than 500 economically disadvantaged patients have been
Dear
supported
delegates,
through
kindly
our
come back to
Poor
your
Patients
respective
Fund,
positions.
made
We are
possible
going to
by the
start the next
generosity
session
and
now.
trust of our donors.
Next, we move on into a practical learning experience session on decoding emergency room X-rays by Dr. Nagesh.
We aspire to deliver the highest standard of healthcare to all who seek our services, rooted firmly in humane and
Dear
ethical
delegates,
values.
due to security concerns of Honorable Governor of Tripura, we kindly request everybody to seated on the dais as early as possible. Requesting all the volunteers to send back the students and delegates as early as possible.
Next, we move on to a practical learning experience session on decoding emergency room x-rays by Dr. Nagesh. I invite all the participants to actively engage in this interactive session. Dr. Nagesh R, Consultant Radiologist, Rashtrotthana Hospital, Bengaluru. Dr. Nagesh is a radiologist with expertise in diagnostic imaging and image-based clinical decision support, having completed his MBBS from Karnataka Medical College, Hubballi, DNB from VMC and RC, Bengaluru, and Diploma in Radio Diagnosis from JJM Medical College, Davangere. He has extensive experience in interpreting X-ray, USG, CT, and MRI studies across a wide range of medical and surgical conditions. We welcome you, sir, for enlightening our knowledge.
Good morning, everybody. Hope everybody is back from the tea break. I'm going to show you some of the emergency room x-rays where you'll be encountering in the nights. Hope you all interact and answer the radiographs. This is a child come with a trauma. Anybody in the audience? Anybody can answer this? X-ray of the wrist. Anybody wants to try? This is, you can just see a buckling here, and we don't see exactly any cortical break in this side or in the medial aspect here. This is called buccal fracture or torus fracture. You can also see there is a fracture of the styloid process here. Okay, 1 minute. Okay. This is another child with a trauma. Anyone? Anyone from the audience? What is this fracture called? You can see the fractures here in the distal 1/3 of radius and both ulna. Okay. These fractures are called green stick fractures, where you can see there is a break in one side of the cortex and the other side of the cortex is not broken. Usually it occurs because this periosteum in the pediatric age group is very strong and elastic. Only you can see little angulation and there will be only break in the one side of the cortex. Okay. This one is another radiograph from a like severely traumatized patient, probably from fall from the outstretched hand or some car accident. So anybody can identify what is the abnormality here? Okay. When you see the AP radiograph, we won't be able to see any abnormality here in these bones. That's why in radiology, it's always, in orthopedics especially, it's always two views. One view is not a view at all. So in a lateral view, you can see this lunate bone which has come anteriorly. This is lunate dislocation. And usually this is how they are placed in a lateral radiograph. This radial head, lunate and capitate are in alignment. They are in a single line. When lunate comes anteriorly and there is an empty space over here, so this is lunate dislocation. When the lunate stays right there on the top of the radial head, but the capitate and the phalanges move posteriorly, it is called perilunate dislocation. So, okay, you can try this one. Anybody? Okay, again you can see this is the radial head here, this lunate bone is sitting on top of it, it's in alignment, but this capitate and this phalanges have moved behind, that's how dislocated posteriorly. This is called perilunate dislocation. Okay. Next one, sorry, this is done. Okay. This is another child, another man probably, with a trauma to his elbow. We have taken a lateral radiograph of the elbow joint. So anyone wants to try anything on this? Do you see any fractures here? Or any signs? Okay. So usually, normally there will be this, can you see this some lucency here in this region? This is the anterior pad fad actually. So this usually, normally it will be present in most of the people. But you can see one more lucency here. You can see this just behind this bone here. So this is called posterior fat pad. If we see this posterior fat pad, this lucency here, it is definitely abnormal. And this, you can see this one is come little bit front here. So this is called Seil sign and this is posterior fat pad sign. Both are there. So that means there is some gross effusion in the elbow joint. So if there is a elbow joint effusion is there, that means there is some fracture around here. I mean like probably in the supracondylar fracture or maybe head of the radius. So there are, most of the time they will be occult. So we should suspect it and immobilize the joint. Still your orthopedician come and examines. Okay. Next, this one, anybody? This is the shoulder joint. Yeah, correct. Dislocation. What dislocation? Which type of dislocation is it? Anterior. Correct. This is the anterior dislocation of the glenohumeral joint. The head of the humerus has come and lied down anteriorly and inferiorly. So this is anterior dislocation of the shoulder. In this case, we should also look for two things, that is Hill-Sachs and Bankert lesions, where Hill-Sachs is the posterolateral aspect of the humerus will be impact and fractures will be there, and Bankert lesion is anterior-inferior aspect of this glenoid bone, there may be a fracture. So you should carefully look for it. Next one. What is this any abnormality here in this shoulder joint? You see any fractures? Do you see the contour of this head of the radius here? There is some abnormality, right? Yeah. This is called light bulb sign. So when you see this light bulb sign, this is posterior dislocation of the glenohumeral joint. Usually this is only 5% of the population will have it, and most of the time in the epilepsy or electric shock, where there is a severe spasm of the muscles, we will get this type of dislocations. This is posterior dislocation of shoulder. Next one. This is simple. Patient comes with a history of fall and he has a back pain. So you see any abnormality in this vertebrae? Yes, there is one compression fracture of this probably L1 vertebra here. Okay, we should look carefully. The concavity here should be maintained, or if there is any retropulsion of these fragments into the spinal canal. So this is the spinal canal here. If it goes back, they may have severe injury to the spinal cord, or like the carda equina nerve roots, because that ends there. So this is spine fractures. Next, this one, can anybody? Yeah, this is a fracture neck of the femur. So this usually in the elderly patient, like our colleague was talking about, like you should look carefully here. There is a fracture here in this place. It's a transcervical fracture. There are some 3 to 4 types of fractures where just behind this is a subcapitate and the transcervical and intercondylar and subcondylar. So subcondylar and intercondylars are extracapsular, and this transcervical and subcapitate are intracapsular, where there is a avascular necrosis is very common in these cases. Okay. Can anybody see the abnormality here? This is a lateral tibial plateau fracture. Usually this will be common in case of the car bumper fractures, where the person hits their knee to the car bumper. This lateral condyle of the femur will impact on this lateral tibial plateau, and we will get this depressed fractures. Next one. Okay. So anyone can pick up any abnormality in this X-ray? This is the foot AP view. Anybody? In this case, we don't see any fractures, but can you make out something? There is some widening here and little lateral displacement of this second metatarsal bone. This one, see, usually the medial aspect of this second metatarsal will be in the line with the medial aspect of this middle cuneiform bone. If it goes away from it, this is called Lisfranc fracture. That means some ligaments here around are broken and it has been given away. So this is called Lisfranc fracture, and this is how it should be. See, this line should coincide, I mean it should be in line with this part. So yeah, okay. So this is patellar fracture. Anybody? You can see here. Next one, any fractures you can identify? So this is usually we see here very commonly, this is the base of the 5th metatarsal fracture. Very commonly we see in our hospital. And this one, this is a fracture of the calcaneum. It's also called lover's fracture, because sometimes they have to jump from the compound to avoid their father-in-law or whoever. So that's a lover's fracture. Okay, this is a patient comes with dyspnea. So anyone can pick up anything in this chest X-ray? Okay. Can you see something here? You can see one thin line coming over here. And can you see this area is divided of all vascular markings? So this is left-sided pneumothorax. Right now it is not, there is no tension, so probably it is not causing any midline shift or anything, but there is a collapse of this left lung along with this pneumothorax. You can see this. Usually this line will be parallel to the chest wall, and as we go to the apex, it will curve. So you should pick up this visceral pleural line. See, if you pick up this line and if you see no markings over here, this is pneumothorax. And like you need to put some, like ICD or pigtail, whatever. So anybody can figure out something here? This is a chest X-ray erect view. Anybody? So normally you can see air here. This is the fundal gas shadow, okay? But we are seeing in the right side, usually this area will be covered with the liver, and most of the time there won't be any air there. Only in exception is the Chilaiditi syndrome, where the colon will come over in between here. So otherwise, if you see this air here, that means there is pneumoperitoneum. Even 1 ml of air can be picked up in a proper erect chest PA view. Okay. This is another patient with a vomiting. So we have done an erect abdomen. Can you see? What do you see here? Anybody? So we can see multiple air fluid levels, and we don't see any air in the rectum and sort of colon also. So this is small bowel obstruction. Next. Okay. This patient comes with a choking and a history of some aspiration. Can you make out anything here in this? You can see this lung is, you can see it is so small, but here it is so big and hyperlucent, hyperinflated, hyperlucent. So, okay, can you see something here? It's a foreign body ingestion. Usually most of the foreign bodies are non-radio opaque, except for this coin and other things. Maybe groundnut, peanut, all those things are radio opaque. Here, if you see this has caused the ball wall mechanism where the air enters and it will never come back. So this is so much of hyperinflated and caused emphysema. Okay, next, this is another person probably on Sunday night where he had some chicken and has some feeling in the throat. If anybody can pick up anything here in this? Can you see something is here, the thin line here, thin radio density? Okay. This is the chicken bone lodged in the esophagus at the level of 6 and 7. This is a common place here, and in the nasopharynx is a common place for this foreign bodies, especially chicken bone, fish bones to go large. So if you leave it for some more days, it will have a swelling, abscess, everything, then it will become very clear to see. Okay. Next, this is the mandibular bone with a fracture here, nothing much. But this is a ring, this is a rigid ring, so you can expect 2 fractures in this picture. Probably there is one more fracture is in the coronoid process. Okay. So this is another X-ray where you can see some soft tissue. This is a blowout fracture, basically somebody hit on the face. You can see some soft tissue opacity here about the maxillary antra here. So it's a floor of the orbit fracture where there is herniation of the orbital content. Sometimes inferior rectus will herniate, it will cause diplopia. So this should give us a clue to say that there is something going on. We should go ahead with the CT and find out that entrapment lesion. Okay. Thank you.
Hello. Thank you, Dr. Nagesh, for sharing your knowledge. I kindly request Dr. Anand Shankar sir, our medical director, to present Dr. Nagesh with a token of our appreciation. Moving on, we now have a practical demonstration on retention and supports by our very own orthopedic consultants, Dr. Sujayendra and Dr. Nikhil Hegde. This will be quite an interactive session through which one would be able to get valuable hands-on insights on the practicability of orthopedic skills. We have with us Dr. Sujayendra and Dr. Nikhil Hegde. A brief introduction of our consultants. Dr. Sujayendra DM, orthopedic consultant, Rashtrotthana Hospital, having completed graduation and post-graduation from KMC Manipal, DNB, Ortho and Diploma, a fellowship in arthroplasty, and multiple certifications in trauma care and fracture management. Dr. Sujayendra comes with a rich experience in managing a wide range of orthopedic conditions. He is also actively engaged in research and scholarly articles with publications and conference presentations that highlight his interest in advancing orthopedic practice through scientific inquiry. We have with us one more consultant, Dr. Nikhil Hegde. Dr. Nikhil Hegde graduated from MVJ Medical College, Bengaluru, and his post-graduation in orthopedics from KMC Manipal. He also has to his credit a number of certifications in trauma care and fracture management, a skilled orthopedic surgeon focused, experienced in trauma, sports injuries, arthroscopy, and joint preservation procedures. He has also been involved in managing complex orthopedic cases. We now have a practical demonstration by our consultants. Over to you, sir.
This mic is bari on madadastella. Check. Mine is working.
Good afternoon, everyone. Welcome to the hands-on session on emergency limb splinting. And since it's a hands-on session, we would like some volunteers to come on, and I'll see if we can get someone to come and pick someone from the crowd. We've been told that we don't have too much time, so we have to cut down on a few things, but we're going to show you as much as we can. So as orthopedic surgeons, we have to deal with trauma management regularly. However, quite often we've been found guilty of having a sort of tunnel vision, of looking only at the bone and missing the bigger picture. So one very important thing to note is it's always life over limb. You should follow a TLS protocol, and the orthopedic splinting, which we are going to show you today, usually comes in the secondary survey, once we know that the patient is okay. And I think we have today Dr. Ashok Puranik with us. I'm not sure if he's here. But anyway, he would be, have much more experience in trauma management. So anyway, our splints today, the objective of all of this is to stabilize the bone, not fix it. So we're going to go through a few different scenarios in emergency management. And the other thing is that in emergency management, the most important thing, it's always teamwork. And you need one person to be the team leader. So we've got Dr. Mahesh here today. And he has to be able to communicate with the rest of the team.
Good afternoon. So this upcoming session is something that is going to be important for all you people, all medical graduates, because at some point you will come across people with injuries, patients who have people who have had who have met with accidents and all. So in the pre-hospital setting, that is outside the hospital, when you come across an injured victim, the basic thing is to check the scene for safety. Make sure that you guys are safe first, and then the patient is safe. If the injury has happened in the middle of the road, try to divert the traffic and this thing. Next, check if the patient is responsive or not. If the victim is not responsive, please call for help. First and foremost thing, please call for help. This is not something to be done alone. Please get the nearby people who are around, get help. Okay, and then as Nikhil told, keep in mind life over limb. Always check, first is life comes first, and then the limb. Now, as medical graduates, you guys should be trained in basic life support. You should all know the basic protocols of basic life support, airway, breathing, and circulation. Now, once these things are stabilized, I mean, either in a pre-hospital setting or in the emergency room, once airway, breathing, and circulation, these things are stabilized, then comes the secondary survey. Secondary survey involves a head-to-toe examination wherein you may come across a limb that is either deformed or a joint that is dislocated. Now, that is when these splinting techniques will help. These splinting techniques are important because, one, it reduces the pain. The moment you splint the limb, it reduces the pain to a certain extent. It prevents further damage to the vital structures. Now, limbs have important nerves and vessels. So, splinting the limb definitely helps in preventing further damage to these soft tissue injuries. Now, in a pre-hospital setting, you can make use of readily available things to splint the limb. For example, you can use newspapers, you can use clothing. We'll just demonstrate how to use a bed sheet if it is available to put a sling on the injured victim. Upper limb injuries are common. Nowadays, we have a lot of road traffic accidents happening with people injuring their upper limb. A simple splinting technique, if you can just use a bed sheet or any piece of cloth that is available to splint the upper limb, this reduces the pain to a great extent. The patient feels a bit comfortable till he is transported to the nearby hospital. Tell.
So you just take a regular bed sheet, fold it into a triangle, like a double triangle, and that can immediately be converted into a makeshift arm sling. So these are just some solutions when you don't have any other resources. The other option, so you just wrap this around and either clip it or tie it at the back. The other option is if the patient is wearing a shirt or a jacket, using the sleeve of the jacket or through the button of the jacket, you can primarily splint the limb without any, equipment that you have. The other option, if you don't have anything, you can use the patient's other limb to support. So, just by folding his arms. So even the lower limb, by tying it to the other limb or the fingers, we call it a buddy tape, where you use another splint. So you can use these sort of things to come up with it. This is all in a pre-hospital. So once he comes into the hospital, then you have these primary malleable splints.
Splints which we can use.
So you don't need to wait for an X-ray, you don't need to wait for any sort of definitive diagnosis. At least you can straight away put this sort of splint and then use some sort of gauze bandage to fasten the arm to that support.
Next thing is the other important thing is while transporting the patient, always take care of the spine. Okay, we have something called as the spine board. You can just show the spine board. So we usually transport the patient on the spine board. This comes with harnesses to prevent movement of the body. While shifting the patient from one trolley to another trolley, or while trying to put him onto a spine board, we use what is called as the log roll technique. Okay, so there must be one person stabilizing the cervical spine. So, and then you have two or three others who log roll the patient onto the spine board and then secure him. See, this is how one person will stabilize the cervical spine at the head end, and the other two people will log roll him. Okay, this is how it has to be done. These basic things prevent injuries. Okay, the spine board comes with harnesses to secure the patient. Next is splinting the long bones of the lower limbs. Now, lower limb fractures, Philadelphia. These long bones of the lower limbs, we usually use what is called as a Thomas splint. Okay, So Thomas splint is used either by itself or in addition to a skin traction application device to splint the long bones of the lower limbs, the femur and the tibia. Okay? The splint is applied and then secured with a bandage. Now, the other thing that you need to keep in mind is before and after splinting, please check for the pulse. You guys should know where to check for the pulse in the upper limb and in the lower limb. You should know how to check for the radial pulse, how to check for the lower limb dorsalis medius and posterior tibial pulses. It is very critical to check and document the pulse before and after applying the splint. Next, for some hands-on demonstration, can we have 2 volunteers willing to come and we'll teach them how to put an upper limb slab. Any 2 volunteers, please come up. When it comes to upper limb, when the deformity is visible, you don't have to immediately get an X-ray. First splint the limb and then get the X-ray. It is much more comfortable for the patient, to be shifted all the way till the X-ray room, to position the limb for the X-ray and all. So, come. Go. We'll just demonstrate how to put an upper limb slab. These basic splinting techniques, everyone should know, because even in your general practice tomorrow, once you start your own practice, you will come across patients with injuries. They may come to you, and you should, even if you have to refer the patient to an orthopedic consultant, you should at least splint the limb and then refer. Again, as we told before, this is a teamwork. Okay, one person doing these things is little difficult. Better to have a team to help you guys out. So first and foremost is we need to pad the injured limb adequately, especially around the bony prominences. If not, these, patients quickly develop pressure sores. It's very critical to pad the bony prominences. Use the cotton padding roll liberally, splint the limb. Yeah. Then we have, once the limb is adequately splinted, we routinely use plaster of Paris, POP, to put a slab.
So the principle of applying this above elbow slab or below elbow slab or the cast is that these are unyielding structures. If you wrap entire limb or entire POP around the leg, it covers it circumferentially, which is unyielding. So in acute cases, we just apply slab. Slab is, it covers only part of the limb, as shown here. There is only strip of the POP, which is ready-madely available, and that has to be applied so that if there is any edema or a swelling in the forearm, that will be accommodated. Once this initial phase gets over, that will take a couple of days, inflammation and the swelling comes down, then we convert it to cast, in which it will be encircled completely. So here we are showing a above elbow slab application in acute setting. Okay? So the principles are, you are supposed to immobilize one joint above and below. Let us say there is a distal elbow fracture. You need to immobilize the wrist. Also, the slab has to go all the way up to the insertion of the deltoid. That's a landmark. and you have to pad it adequately, particularly over the bony prominences. For example, radial sternum, ulnar head, and medial and lateral epicondyles, polychronum, and these are the places you need to give extra padding. And POP, while applying, you will have to mold it. You have to reduce and you have to mold it. You will have a working time of about 5 to 10 minutes, which depends upon the temperature in the room and the temperature of the water which you soak it in, the electrolytes and the amount of POP which is available. Okay. So once you mold that, it takes about 10-20 minutes to set, and for complete setting it takes up to 24 hours. So what are the instructions you need to give to the patient? You need to inform them about active finger or toe movements so that the circulation is maintained, and what are the warning signs. If the fingers or the toes becomes bluish discoloration, or if the patient is having a lot of pain, if there is a stretch pain which is indicative of a compartment syndrome, these are the red flags you need to inform to the patient and ask them to come immediately to you or emergency. Once this slab is applied, then you ask them to maintain it properly. It has to be maintained, the hygiene has to be maintained, and it is not supposed to be soaked in the water. Now there are fiber casts available, but still these basic instructions hold good.
Other thing is you should know in which position of the limb to use the splint in. If you are putting an above elbow slab, as you see here, the elbow should be placed in around 90 degrees of flexion. You cannot keep the elbow straight and then apply the slab. This is not the position to put the slab in. When it comes to lower limb, for a below knee slab, always keep in a below knee slab you are immobilizing only the ankle joint. The ankle joint has to be immobilized in neutral position, not in plantar flexion, not in excessive dorsiflexion, in neutral position. In case when you have to put an above knee slab for an injury around the knee joint, you need to immobilize again the ankle in neutral. The knee has to be in 20 to 30 degrees of flexion. Okay, these positions you should remember. For a below elbow slab, the wrist should be in neutral. Here you can see that the wrist is in neutral position, the elbow is in 90 degrees flexion.
We had a few more splits planned, but I think we'll have to conclude early because we're running out of time. Another thing is, which we did, we made him sit for demonstration's sake. Usually if you have a sick patient in the casualty, you don't make him sit at the edge of the bed because you'll have to end up putting more splints on him after that. But that is purely so that everyone can see what's being done. Others usually make him lie down and make sure he's secure. So we will conclude. Just a few points that you should remember. One, the most important always is your ATLS protocol, airway, breathing, circulation. The limb comes second, always life before limb, even if you're an orthopedic surgeon. Always work as a team, make sure you call for help, you're not doing anything as a hero. In terms of the splinting, few things to note is always your pulse, motor and sensory. You have to know the neurovascular status before your procedure, after your procedure, and make sure you document everything. Everything in an emergency setting has to be noted down, however hectic it is. The other things, like we mentioned, adequate padding, immobilizing one joint above, one joint below. So these few things we can remember, I think we'll be okay in an emergency setting. Thank you.
Thank you, doctors, for such an interesting and insightful session. I kindly request Dr. Anand Shankar sir to present a token of appreciation to all our doctors.
Yeah, Alok Tekuli. He wants his one solo photo.
He's a real patient.
And a special thanks to all the volunteers who helped in the session as well. While we get ready for our next panel discussion, we have an interesting quiz competition now under the guidance of Dr. Prashant. Dear delegates, please use the QR code present on the screen to access the questions. You'll have 10 minutes to complete the quiz, and results will be declared based on the top scores, and you'll also have interesting and exciting prizes at the end of the session as well. So kindly hurry up. We have just 10 minutes to complete the quiz. Meanwhile, we'll prepare for the panel discussion. Also, a gentle reminder to all the delegates, if you have any doubts or questions regarding the session, you can write it in the chat, the sheet that is given, and we'll be collecting it, and our resource persons will be answering it in the panel discussion as well.
I hope you all have finished your quiz by now and submitted your responses. We'll be closing the quiz soon, and next session would be panel discussion. So we'll start with the panel discussion. I invite our chairperson, Dr. Ashok Puranik sir, and other panelists, Dr. L.S. Praveen, Dr. Mahesh Kulkarni sir, Dr. Nagesh, Dr. Sujayendra, Dr. Nikhil Hegde, Dr. Prashant A.L., to please take their places on the dais for the panel discussion. Any of the delegates, if you have any queries, you have a question sheet in your kit which is provided. Please write it down and hand it over to the volunteers. This will be discussed in the panel discussion. Before we start, we have a small felicitation to Dr. Ashok Puranik sir from Good Shepherd Institute. I request Dr. Helen, founder of Good Shepherd Group of Institute, to please present the memento.
That's fine. No hurry.
We have a couple of questions. The first question is to Dr. L.S. Praveen sir. The question is, which is better to visualize the nerve imaging? That is it, which is better to visualize the nerve? Is it CT or MRI?
MRI, soft tissue, whenever you want to assess the soft tissue, MRI, no question about it. But it can, if it is, in fact, between CT and MRI, MRI, but we can visualize nerves even in ultrasound also. Okay, I think I have answered your question.
Thank you, sir. We have one more question to Ashok sir. Could you please explain your experience in handling the cases on field? How different is it to handle it in the field from the hospital setup?
Cases in the field. Field, you said?
Field, your experience, sir.
Okay. So before I answer that question, how to handle in austere measures, basically, in a very difficult situation, okay? So audience, I want you to ask me one question, कि आप शादी के पहले क्या करते थे? पूछो? Somebody? Okay, शादी के पहले क्या करते थे? वही करता था जो मेरा मन करता था. Okay. So, you know, I have been to the field in Sri Lanka, I have been into the field in Himalaya, the whole Arunachal, I have been into the desert in Rajasthan, I have been into the Kargil. You know, the working over there is, we call it as austere measures, कि आप कमी वाली जगह पे आप कैसे काम करते हैं. So the first challenge is the weather. Okay, when you are in a desert, you have to really be getting the patients with the heat stress, heat stroke, dehydration like that. So you have to keep that particular geographical location in mind. Similarly, when you are in a high altitude, so you should be knowing about the weather-related condition. Like when you are in a high altitude, you'll be getting chill blends, you'll be getting frost injuries, you'll be getting hypothermia, you'll be getting a pulmonary edema when you are in a high altitude. In desert, again, you know, there is our sandstorms, you'll be inhaling. So it depends, the injury depends on the weather, temperature, and the overall environment. So you should be taking care of the patient accordingly. In a heat stress area, you require a proper cooling room and with the facility of the ice. Similarly, in high altitude, you ought to have some warmer, blanket warmer. And let me tell you, our 40% of the patients which come from trauma evacuation from the anybody else, 40% of the patients are hypothermic. And the moment patients are treated under hypothermia, if you analyze the dying patient, 70% mortality is increased by hypothermia. You know, so we have to work in a tent. We have to work in a makeshift hospital. I can tell you when I was in Manipur, the hospital had just a rectal table and a routine surgery instrument, and I got 3 cases. 3 cases of splenic injury, head injuries, dislocation, hip, knee, and all that thing. So you ought to be a bit multi-trained, you know, multitasking. That is what is required. Incidentally, I happened to work in army at various locations, so I picked up everything right from the gunshot wound to the missile injuries to road traffic accidents. And being surgeon, I have been doing cesarean also, you know, because in Assam, there are soldiers who quietly keep their wife and keep in the village, and when there is a labor pain, they bring to the nearest hospital where there is no supposed to be gynecologist. So as a surgeon, you have to work many times like a gynecologist also. In austere measures, you should, the thing is that the advice I would like to give that you must have few things ready-made at your place, like anaphylactic tray. It's a very basic, simple thing, you know, that certainly you are looking for hydrocortisone nahi hai, adrenaline nahi hai, all those things. So the first aid, everybody should know, and you should have that particular trolley. Second is you ought to have a suturing packets. You know, if you don't have the suturing packet, you can use stapler nowadays. So there are so many things which can be, when you don't have a tourniquet, you can use IV tube lines or a Foley's catheter like that. You should have an adequate size of catheters. You should have adequate IV fluid stocking. You should have a kind of painkillers which is required every day. Like you should have a paracetamol, you should have a tramadol. If somebody not responding, then you should have a combination of it. And if somebody require morphine, you ought to have a license for that. So I can go on and on. There are so many things which in austere measure we should be applying. The thing is that safety has to be in mind. You know, any patient, any awake patient coming to you should survive. Any patient hypotensive, you should be able to kind of bring him his blood pressure. And anybody who is not breathing well, you should be able to intubate. If this, my 2 messages goes to the audience. If you know the art of intubation, if you know how to resuscitate the hypotension, 50% of the death can be prevented. 50% of the death can be prevented. You have to learn these 2 tricks, 2 skills. This is for everyone, whether you are a nurse, whether you are a paramedic, I think you should pick up that. When you pick up the patient, they should be in left lateral position. Always make the patient lie. Always put a blanket, okay? So that the patient doesn't drown off his own secretion. And otherwise, everybody should learn these tricks of airway, breathing, circulation, disability, and environmental care, I already told you. So these are the pulse of wisdom at the moment.
Thank you, sir. We have one more question to Dr. Mahesh, sir. This is from Vignesh J. Do you think Ayurveda and other traditional medicine system will be helpful when integrated in geriatric care, especially in improving movements or bone health?
Definitely yes. They have this is integrated medicine approach that we are focusing nowadays upon. So the Ayurveda is a way of living, that's a lifestyle, and that obviously helps to maintain your health, and particularly in the elderly people who are having a degenerative diseases, the solutions in the they give results, they yield a proper results. In selected cases, yes, we need to go and intervene, but as a whole, Ayurveda and our naturopathy and our other native system of medicines, they do work wonders.
Thank you, sir. Any other questions from the audience? I think we have come to the end of the panel discussion. Sir, I would like our chairperson to present the concluding remarks.
Yeah. So as I said, you guys didn't ask me the question कि आप शादी से पहले क्या करते थे? शादी से पहले मैं वही करता था जो मेरा मन करता था. Okay, अभी मैं कुछ भी नहीं कर सकता. Even चैनल भी नहीं चेंज कर सकता. तो आप सब यूथ के लिए मैसेज ये है कि आप एक जिम्मेदार नागरिक बने, कानून का पालन करें, अपने परिवार का ख्याल रखें, अपने स्वास्थ्य का ख्याल रखें और सबसे बड़ा मेंटल हेल्थ, यू नो. एंड मुझे एक चीज़ यहाँ पे बहुत अच्छी लगी कि हम अभी एक इंटीग्रेटिव मेडिसिन की बात कर रहे हैं. तो आयुर्वेदा और योगा इज़ गोइंग टू बी इंटीग्रल पार्ट ऑफ आवर लाइफ विच वी हैव फॉरगॉटन. द होल वर्ल्ड इज़, अगर आप गूगल करेंगे तो आप पाएंगे कि सारे वर्ल्ड ने पूरा अपना लिया है योगा. दे आर सो मेनी योगा एक्सपर्ट्स and yoga is a big business outside in America and UK and Australia, let me tell you. And I was telling to other 2-3 youngsters who met me that please join some kind of a health course, upskill yourself. You know, whether you are a lab technician, whether you are an ECG technician, EEG technician, plaster technician, OT technician, ICU technician, ortho technician, you know, endoscopic technician, there are so many jobs available. So, and it's you are serving the humanity, you are paid well, your life is with the good people, in a good building, in a good environment, so that you remember my story that the life should be full of the gratitude. Your attitude should be, you know, having a life, gratefulness, thankfulness, you know. आपको एक thankfulness की एक feeling हरदम रहना चाहिए. You should always feel blessed. You know, so as a healthcare personnel, we all are blessed. God bless you. Jai Bharat, Jai Karnataka, Jai India. Thank you.
Thank you, sir. So we have come to the end of the panel discussion. Thank you, our chairperson and all the panelists who were here. So regarding the quiz, we have got 196 responses till now, and Dr. Prashant will be discussing about the quiz questions, and he will be announcing the results as well. So he will be explaining about what this quiz was really about, and he will be discussing about the questions.
morning everyone, I am Dr. Prashant. Today I will be discussing the quiz questions which we have participated. I congratulate all the participants who have participated in this quiz. First question was to identify the pathology location. So this was a case of bilateral pneumothorax. You see the opaque collapsed lungs on the both sides, and you see the air filled in the bilateral pleural spaces. So this was a bilateral pneumothorax case. This was the question, but this image was not given in the quiz. This was a buccal fracture because there is no cortical break, but there is bulge in the metaphyseal end of the distal radius. As you see, this is a AP X-ray of the both hands in a child who is having bowing of the legs and delayed walking. And in this, you see there is indistinct margin of the metaphysis and there is widening of the metaphysis of both the distal hands. And there is also cupping. So this case is rickets. This was MCU investigation which we do to see the vesico-ureteric reflex. This is the bladder which is filled with the contrast, and this is the ureters on both the sides which has reflex while micturating. And we have different grades to categorize this reflex. This was a grade 5 vesico-ureteric reflex. This was a case of pneumoperitoneum because there is air under the right side of the diaphragm. This X-ray was given to identify the location of the ET tube, whether it was normal, malpositioned, or any pneumothorax or something. So this is the ET tube which you can see. You can see the tip of ET tube is in the right main bronchus, and that is leading to collapse of the left lung. So how, where is the normal ET tube should be located in the normal location? This is the normal location, just 5 centimeter above the carina. This is where the ET tube should be located. But in this case, it was in the right main bronchus. So answer is malpositioned ET tube with collapse of left lung. In this, we'll have to identify, there are different joints in the given X-ray. We'll have to identify the joint which is dislocated. The answer was acromioclavicular joint dislocation. This is the clavicle and this is the acromion process. You can see the clavicle is above the acromion process and the distance between coracoid and acromion is increased. Usually this is the normal position of the clavicle in normal patient, but in this there is AC joint dislocation. ALARA principle, this can be a neat question for UG students. ALARA is as low as reasonably achievable. We use this technique to reduce the radiation dose to the patient. How we do this? By reducing the exposure time, reducing the radiation exposure time to the patient and increasing the shielding of the patient by using the lead. And also, in this question, the patient came with the patient diagnosed with a ureteric colic, and what is the best investigation to go ahead with? Not the ultrasound, not the ureteroscopy, not the CECT abdomen. It's just a plain KUB to identify the calculi in the ureter. This is the calculi in the ureter which is causing hydroureter nephrosis in the left kidney. What is PIRADS? PIRADS is Prosthetic Imaging Reporting and Data System. This is to characterize the malignancy of the prostate using the MRI. It is from 1 to 5, where 5 is highly suspicious for malignancy. This sign is Mickey Mouse sign. We all know that. All options has Mickey Mouse. But we have to identify the structures which is formed by. The face is formed by common femoral vein. The left ear is formed by greater saphenous vein and right ear is formed by common femoral artery. So the A was the correct answer. So what is this investigation? This is HSG, hysterosalpingogram. This has uterine anomaly called bicornuate uterus. This is the corresponding MRI where there is two endometrial cavities filled with the contrast. So the fast is updated to E-fast now. That is called extended fast, where we evaluate the pericardium, right upper quadrant, left upper quadrant, suprapubic area, and bilateral pleural spaces. So we evaluate totally 6 places actually, because the bilateral pleural spaces and perihepatic, perisplenic, pericardium, we see the fluid to rule out injury to the solid organs. Here we have to identify what is the pathology and there is midline shift or not. This is the CT image where we see the hyperdense collection in the left frontal lobe, and that is causing midline shift. This is the septum pellucidum which is displaced towards the right. How do we measure the midline shift? We draw a line anterior to posterior in the midline and we calculate the distance between septum pellucidum and midline. This is how we calculate the midline shift. This is anatomy question where we identify the structure on. This is the central lucent area, tube-like area. This is trachea. Trachea was the correct answer. In this X-ray, it was critical to identify the situs inversus because there is right apex of the heart is displaced towards the right. Stomach of the air bubble in the stomach is seen on the right side. This was situs inversus, and the propensity of the patient to develop bronchiectasis, sinusitis, and infertility is more in the cartaginous. This is the triad in cartaginous syndrome, where all these components is involved. Which is the best CT contrast, oral contrast for the CT to in a perforated bowel case? The gastrogastrian was the correct answer. This was the sagittal image of the MRI. The arrowed structure is intervertebral disc space. In severe CKD patient, which is the safest investigation to identify pulmonary embolism? There we don't go for contrast CT scan because it might cause increase in creatinine levels, and MR can't identify the thrombus. Non-contrast CT also cannot identify the thrombus. So VQ ventilation and perfusion scan can give the diagnosis. He is Terry Thomas. He had a gap between two teeth. This sign is used in scapholunate disassociation. This is the gap between two bones, scaphoid and lunate. We use this sign in scapholunate disassociation. Thank you. Thank you. Now I would like to announce the winners in this quiz. Narendran is Nidhi Rajput and Smita T. Smita T. I would request all three of you to come on the stage to collect the prize. Narendran, please come. Second prize goes to Nidhi Rajput. Third prize to Smita T.
क्या कीजिएगा इतनी धनराशि का?
Congratulations to all the prize winners. Now I request Ashok sir to felicitate Dr. Prashant for
So Prashant, you read? You read? You have to read the complete book. Next MCQ will be on this. Congratulations.
So Dr. Prashant, our radiologist, was the one who has framed the questions for this quiz, conducted this quiz, and so I hope it was all interesting. So here we come to the end of this Foundations to Fitness. I hope you have all learned a lot from today's session. Thank you very much. I request all the delegates to please proceed towards your lunch. Your certificates are ready at the registration counters where you have registered today morning. So you can hand over your feedback forms. Your forms are in your kits. Please hand over the feedback forms and collect your certificates. Your lunch is arranged behind this auditorium onto the right side. So you can proceed for your lunch and certificate collection. Thank you so much. Thank you very much.
Health does not merely mean freedom from illness. True health lies in nurturing both the mind and the body